Caroline, in your rotations, have you had the opportunity to use osteopathy with kids any? Have you seen any babies or children where you've been able to use your training to help them in ways that MDs don't know how?
Only in your clinic. Actually, no, that's not true. On my pediatric rotation, I did have, this was in Walnut Creek, and I had a teenage female who had some shoulder and chest pain. Chest x-ray, EKG, physical therapy, and still some chest and shoulder pain. And so my MD preceptor encouraged me to go in and work with her and the mother and see what we could do together and see if I could come up with another explanation, because their traditional modality wasn't really providing anything. And talked to her about her school, did a physical exam, was able to kind of compare some asymmetries that seemed a little bit more chronic in nature than acute just from her tissue, and then looked around the room and saw her really pretty designer bag. Not a backpack, but a one-strapped bag. And so was able to zoom out a little and ask more about how you carry your books, how many books are you carrying, is there a laptop in there, what's the weight of it, how do you carry it? And it became very obvious to the mother, the patient, the child, and myself that there was a pretty obvious explanation for her chronic neck, chest, and shoulder pain. That she thought she had anxiety, she thought maybe she had a heart condition.
See, so something as simple as a rib spasm could be completely misunderstood and not even correctly diagnosed, much less the cause of it. So which your exam, not only were you able to identify the source of her pain when these other tests couldn't determine it, but that you were also able, from the physical exam, to figure out what the patient was doing that was causing it, that would have perpetuated it. Because even if you treated that pain in the bed and got it to go away, as soon as she started carrying the backpack again.
Right, so we were able to have a group educational moment and say, maybe we need to find a different way to carry your books, maybe you need to lighten your load a little, and let me make you physically aware of what this is. We did identify the problem rib. We were able to put her in say that this is what hurts, this is your position of ease, and really just as a diagnosis that this hurts, this is ease.
And so this is where a physical exam, when you understand osteopathy, is also part of the diagnostic process.
And again, with my MD preceptor present, we were able to hang out in ease for a short period until she felt the tissue relax, and I was able to agree with that. We didn't stay for the your traditional 90 seconds in a counter strain or anything. It was really just introducing her into what hurt and what felt good for her body and how her body could relax in that position, and then no longer interpret it as pain, chronic pain.
Right. But she understood the mechanism of the pain differently.
Indeed, and we were all able to speak about the physiology of it together and why that hadn't been easily identified on the previous tests that were medically indicated as far as her pediatrician was concerned.
Right. In the context of helping her really get over it, being able to reassure her and knowing the real mechanism of her pain, where it was left to some ambiguous, boogeyman kind of, it's going to get you pain.
Right.
Nobody knows what's causing it.
Well, and they weren't even really trusting the EKG, because what if the EKG wasn't catching the moment of her pain? So it really did provide, I think, a sense of ease to have a logical explanation that fit in with her experience for the rib.
Right,
the displaced
for the doctors, but even for her, where the anxiety,
patient, that was a huge relief.
Yeah.
As a young teen, she was certainly
like
concerned.
Suddenly, there was an easy explanation that didn't mean that she had some lifelong condition, nor was her health ruined. And that's the important part. When we're young, we know we still have our perfection. And one of the things that we experience as we get older and experience diseases is we fear that we're going to lose our health, our perfection. And sometimes when patients are really sick, they're afraid that they have gotten to the point where they can't get back.
Recover.
And see, reversibility is the hope, that should be there. Now, it's true that as physicians, we're taught that we should never give the patient false hope. But I was told by one of my other students that the difference between how I approach pain with my patients and other practitioners he'd seen in pain offices was that my patients had hope. But it wasn't in an unrealistic type of hope. It was hope based on understanding, education of the patients. He also said this, He said that in watching this other man work, that he spent about the same length of time I did with patients, and his whole interview was asking questions, trying to figure out the mechanism of the pain and what they could do to interrupt it. But he said that the difference was, because I used perceptual transference, that when I walked into the room, I seemed to instantly know what was wrong.
Mm-hmm.
And then I spent the time explaining to the patient why they had the pain, which was kind of inside out of how this other doctor worked. But the other key element was that in that office, all the patients were in despair because they were taught this is the best it can be, you can't expect to get better. And basically they weren't given any roadmap of how they might really recover their health. It sounded realistic. It was all kind of just lumped under, live with it. Mm-hmm. And in my practice, that he saw that by helping them feel the areas and come to understand them mechanically and physiologically, that they weren't given false hope, but they were given an understanding of what was wrong that enabled them to feel that they had some measure of control and that they might overcome it or deal with it more successfully.
And that their body is inherently seeking that health down to the cellular level. It's striving for homeostasis. And I think, again, if you remind people of their natural physiology, it's striving for that perfection.
Well, I think that the way that the disease model, it permeates the culture, is it's a slow downhill slide model, and everyone's afraid that they're going to start sliding downhill. And so, especially young people who've never been sick, anything that goes wrong is terrifying because they're afraid that this is going to be the event that marks their beginning of the end. And in some ways they're correct, and how much you accumulate dysfunction and stress does definitely wear the system out. But whether stressors are trivial or not, and whether the core algorithm preserves its perfection or not, is up for grabs. And even in advanced and complicated disease states, bearing in mind these concepts and using them in the hierarchy of making clinical decisions is a really important element of my practice that I don't think other doctors take into account.
There's one other physician I've had the opportunity of working with out in Indianapolis, Dr. Charlie Beck, and speaking with you, I'm reminded of looking at the teeth and how all the intraoral components come together and drive the rest of the body developmentally, the same way you spoke about the feet. Driving the gait and the
it's
development.
all interconnected.
And so this other doctor, I was able to work with him for 2 weeks and watch some intraoral work done prior to orthodontist visits with young children. And ideally creating functional symmetry prior to having devices implanted or positioned and giving them the best possible potential for symmetrical growth.
Right. Just a couple of weeks ago, I saw a young man who's 15 years old who I had treated as an infant for a cranial dysfunction after birth. And even though I released that child when he was about 18 months old with the warning of to the parents that he might develop more asymmetry, and if they saw asymmetry still operating, that they should bring him back to me. They waited 14 years. And so at 15, he had orthodontics. And the trouble was that the orthodontist did not understand the cranial concept. So while his teeth were perfectly beautiful, his chin was a ½ inch to the right of midline. And sure enough, he was having symptoms from it. So the cranial concept in babies is important in preventing skull distortions, but it has a very relevant role in orthodontics and in dentistry as well. We had the only ADA approved course in cranial